Welcome to our newest edition of Treat Live here at Mount Sinai. I'm super excited to be here today with everyone and to introduce this awesome live case. We have a great case of hemorrhoid artery embolization here. We're actually filming on our West Side campus over at Mount Sinai West. Super excited about that as well. In addition to our staff here, we have a special guest today from UCLA, Dr. Jessie Stewart. Thanks for joining us, Jessie. Without further ado, I'm going to head over to the lab, and Dr. Vairamurthy and Dr. Shilo are here, and they're going to present the case for everybody. Thanks.
Good morning, everyone. Jay, got Dr. Shilo with me, and just want to say thanks to the anesthesia team, the nurses, the techs, everyone that made this case happen today and are continuing to support. Also like to thank all the support staff and the AV people from the Treat Live series for making this so seamless. We have a fun case today. Hope you all learned something from it, and I really appreciate Jessie waking up early on the West Coast to be here. And thanks again. I'm going to pass it over to our PGY5, Linzi.
In 3 days, yeah. Hi, everyone. My name is Linzi Webster. I'm a Rising 5, and I'm an IR integrated resident, and we're happy to present this case. So we have a 25-year-old woman who initially came in 2 years ago with dizziness, lightheadedness, and bright red blood per rectum, and further workup of colonoscopy demonstrated hemorrhoids and only hemorrhoids. She continued to have pretty significant bleeding despite conservative management, requiring numerous IV iron transfusions and numerous blood transfusions. Most recently, yesterday, she got her last transfusion. Next slide, please. So she's on daily IV iron, daily B12, incentive for the constipation the iron causes. She has no other past medical history. Her family history is significant for hemorrhoids on her father's side. And in terms of her surgical history, she underwent banding approximately 3 months ago. She's hemodynamically stable. Her labs yesterday demonstrated a hemoglobin of 8.3 after her transfusion, appropriate platelets, a normal INR, and appropriate renal function. Her exam was unremarkable with palpable radial pulses. In terms of her imaging, she had a CT from 2022 that demonstrated conventional anatomy and no acute pathology. When we worked her up in the clinic, decided that she didn't need any subsequent imaging. And so our plan was to bring this 25-year-old woman with grade 3 internal hemorrhoids causing severe anemia and transfusions despite banding to come in for mesenteric and pelvic angiogram with possible embolization.
Great. Thanks for doing that, Linzi. Yeah, pretty significant 26-year-old now with anemia requiring intermittent transfusion. You can see the impact it's really having on her quality of life. That's something that we don't want. I'm glad she was seeking out treatment. The way she came to us actually from a colorectal surgery colleague that we share patients with, and she kept hemorrhoid artery embo in mind for her, especially because she did have a banding that ultimately did not hold. She has grade 3 prolapse, grade 3 hemorrhoids, which makes her a good candidate for these. Jessie and Aaron, are you on the call now?
Yep.
Yeah, I can hear you guys great. Thanks for presenting this case, Jay. So before we talk a little bit about the clinical situation, I just want to hear from you guys both what the setup is, how you started the case, the access, and where you are right now, and then we can talk about the clinical aspects, which I have a lot of questions.
Yeah, I mean, in honor of the great Aaron Fishman, I went radial, doing more and more of these radial. The femoral access is great, and you could really get into the IMA pretty easily, especially with the rim catheter, 65 rim, and kind of go through things pretty quickly. I saw her earlier, in office hours, and kind of went through everything with it. She kind of expressed a preference to go radial if possible. So we scanned her, outside in the holding area, and she had an appropriately sized radial. And so I have a 4 French 125 aquatempo catheter here that we use to select the IMA. Admittedly, getting into the IMA from radial, I always have to spend a little bit more time than from the groin. So pick what you're comfortable with. But
Jessie, what do you use typically for access? Are you using radial or femoral or both?
I do both. Yeah, and I do both, kind of depending on the patient. We've had a few octogenarians come through, so I tend to go femoral for them. But yeah, I've used both. I think both are great. So yeah.
And when you do radial, is there a specific catheter that you like to use?
I've been using a 110 TIG, something in the 110 range. But I mean, you could use, Jay's, using like a 120. It's just it depends on the microcatheter. You might need a longer microcatheter to kind of reach distally, to get more selective. So, I'd like to use the 2.4, but if you're using like a 2.0, then you could use 165 length and and make up for the length that way that you need without having to go in too far with your parent. So
yeah, I actually
based
I
on where
like
we
the
are
Sarah
now, it looks
radial
like
for
Jay
that.
picked the perfect
yeah,
length.
Sarah, that's
Yeah.
also like
Yeah.
110. So yeah, I mean anything like that would be fine. Yeah.
So right now I have a 125 catheter and a 150 2/4 prograde through that.
Okay.
Yeah, and I share
May
your
not
concerns
be-
about
Yeah, like how
as
tall?
far as she is like 5'6".
5'6".
Yeah.
Yeah,
Not
so you might be okay. I mean, yeah, we'll see.
You know, there is a
I mean, that's
technical
tall by
point
my
I think
standards.
that's interesting here. When you have a young patient and their aorta is very narrow, I think the vertebral shape is fine. When you have an older patient, I do think that the wider aorta, it's harder with a vert shape to get into the IMA, and so that's where I sort of find that, as Jesse mentioned, the TIG or the Sarah would be more beneficial for that scenario. Do you guys want to show us the angiograms and show us what you've done so far?
Yeah, we're going to have to go back. I'm not sure we're going to be able to show the initial run. We had a little bit of a technical error as we changed things, but we can definitely show a DSA of where we are now. We selected the IMA by radial, and then Jay expertly navigated to exactly where we want to be. So he's going to show you exactly where we are now.
I'm going to do a little hand run here, and we'll try to get the original IMA run up at some point. But
so I think it pretty well demonstrates where we are, where we just cannulated IMA, went down south to the superior rectal.
yeah,
Jay's
and you can
away all the drama of getting there, you know.
Yeah, we didn't want to keep you waiting. I mean, you already so early to help us. So
So just to be clear, I did an IMA run, which we'll try to show at some point. We're just having a little technical issue, and then I selected a right-sided superior rectal artery, and I think it's a very good demonstration of the pathology that we're trying to treat here with the corpus cavernosum recti. You know, and you can kind of see that draining veins, kind of consistent with the underlying pathology. This being more like on the AVM range than a true parenchymal staining pattern. So for that reason, I mean, I know there's some, not controversy, but mixed opinions on whether to do particles or just coils alone. And for me, I like to do some particles just conceptually to try to get into the distal communications with possible middle rectal and inferior rectals. You know, and I was using 5 to 7s. More recently, I've bumped it up just because I had a couple patients with pain for a couple days, and which is to be expected. But I'm thinking maybe if the particle size is a little bigger, maybe it's a little gentler. Because
This is such an interesting concept, Jay. I think that the choice of embolic here, we all know that coils are sort of standard here, but the addition of particles, I think, is important, at least based on the data. Jesse, tell us a little bit about your opinion on particles plus coils versus coils alone.
Yeah. So, I mean, I do a very small amount of very dilute particles, kind of just to decrease that blush that we see in the corpus cavernosum recti. And again, we don't want them getting, anal pain, syndrome and things like that. And that has been shown. There was a study where they did stasis with only particles. And there was definitely, more pain, with that kind of volume. Now, no ischemia happened, but they definitely had more pain, especially with the smaller sizes. So I just do a very, very tiny amount. I'm diluting up to like 20 in the vial. So I'm talking about starting with usually 0.3 or so. And then doing really a maximum in a selective branch like this of about 1 mil of those dilute particles. But I think the bigger size is fine too, Jay. Plenty of folks will do the 7 to 9 size as well. To me, sometimes those vessels are just so tiny in that little, area of blush that I want to make sure I'm getting a little bit distal into that. But I think both of those sizes are perfectly fine. I think this is a great location here. You're right above the CCR. I don't usually coil below pelvic brim, so I think this is a great spot to give a little dash of particles and coil it.
Yeah, I think it's the knowing where to embolize. I think it's pretty easy to embolize pretty proximally or convenient, I would say. And I have seen some of the redo cases that I've been referred of really proximal embolization. So because I've seen those, I've become a little bit more persistent with getting, as close to the pelvic brim as I can. I don't want to go too distal, but this is where I spend my time.
Sometimes they get pretty pretty small, higher up, so you might not be able to. But yeah, I mean, around the area that you're at right now, I think is ideal. Looks like you're having no trouble with reaching there with your micro, so that's great.
That was a great move. You just slid it down.
Are you very slick? Is your parent catheter pretty much hubbed at this point? Or?
No, I still have some wiggle room. I have it basically in the superior rectal origin up high.
Is your microcatheter hubbed? Or?
Yeah, that's hubbed now.
Okay. Right. So that's about you're not going to
find something
further than that. So
these vessels to me are more prone to spasm than any other vessel that I routinely select and all that. So I have nitro on the table ready. Fortunately, I'm not going to give it now because I feel like we don't need to. And I'm just going to give.
I know some folks are giving nitro, but this isn't like a prostate where we're trying to force in a lot of particles. So unless there's a spasm, I'm not giving nitro because that's not really
You also wonder, at least I wonder when you give nitro in this vascular bed that you're going to open up, different branches,
exactly.
different collaterals, middle rectal, things
beneficial. That's beneficial physiology for us in this.
I have a 1cc thing.
Yeah.
Definitely.
As you guys are putting the particles in, you said you're going to use 7 to 9. Is that right, Jay?
Yeah, I'm only going to give 1cc of it.
Okay, so you're going to give a small amount, and then as you guys deliver those, I'm just going to ask Jesse another question. This location, right at very proximal to the CCR, this seems like, in my opinion, the best location. But there's a lot, as Jay was mentioning, there's lots of people that embolize much more proximal. So have you found, at least in your experience, at this location, at least putting a small coil here gives us sort of the best possible outcome and maybe decrease the potential risk of recurrence? Or do you think it really doesn't matter too much?
I'm just going to give 1cc.
Yeah, I think this is a great question because, these things can open up and reperfuse from other areas and things like that. And, I think me personally, I want to get as selective as I can because I want to spare normal rectal perfusion as much as we can. But then other arteries can open up and go to that, can kind of reperfuse that area, which we've seen happen. They've kind of started contributing to that CCR. So, I think in general, most of us are getting as selective as we can. But, I think, a lot of people go more proximal, of course. I don't think we've really teased out in the literature which one's going to be better as far as recurrence goes or length of procedure, things like that. But yeah.
So these are
always a little chunky with these.
Yeah, a little chunky. That's a 2-4 prograde, you said, right?
Yeah.
Yeah. So one of the things about this case as compared to maybe a knee or a prostate is that the microcatheter size doesn't have to be super small necessarily. I mean, you could see how distal you got this 2-4 pretty easily down to that spot. Are you ever using small catheters like 1.7, 1.9, or you don't think it's really necessary for cases like this?
I have, but I feel like the 2.4 is great because you get really good imaging and give your particles easily. So that's what I tend to use. But yeah, I've done a 2.0 as well in some cases.
It might be hard, Jay, to get the 7 to 9 through a 2.0, I would imagine, right?
I'm not gonna.
Yeah, you'd have to
be a little stinky.
Push the 5 7s through there, I think. But yeah.
Yeah, the issue wouldn't be the coil; it would probably be the particle.
All right.
Do we have what do you guys want to use for coils here as you sort of think about the next step?
I personally use the soft coils from the Embolization.
Okay.
I find that they work with again, I just find these vessels to be very sensitive, and when I was trying the fibered ones, I was not comfortable with the placement of them at times. So I've switched to the soft coils. And, I call them the J coil sometimes for this purpose. But for this one, I use either a 2 or a 3 millimeter coil. For this one, I'll use a 3 millimeter. This is a 15?
315.
315. We'll have a 315 Embolization soft here that we will
dunk in the bowl.
Deploy here.
Do you think that vessel is going to handle a 3, or do you think because I'm looking at the size of the vessel, I wonder if the 3. I mean, I know the soft coils really probably doesn't matter too much because they're gonna coil pretty easily.
But even if you get pushed back a little bit, I mean, I don't know that that's any type of disaster in this location. I think that'll be totally fine.
Yeah, I agree.
Yeah, I'm
what
using.
coils are you using, Jesse? What do you like to use?
2s or 3s. Usually, I mean, like an 8 centimeters, nice. I feel like that usually takes care of it with one. But yeah, I mean, a little longer, it's not going to hurt anything here.
What does everybody think about the choice of detachable versus pushable? Because a lot of we're going to be using a lot of coils in a case like this. And so how do we navigate through the cost of these higher level coils versus the number that we have to use? What do you guys think about that?
Honestly, I think pushable would be fine too. I mean, at UCLA, we just think the most expensive way we can. So it's
yeah.
In
terms of pushable,
the most expensive or the least expensive?
The most expensive.
Sad. That's beautiful.
Yeah, that's really nice. It's packing well. I mean, I was thinking it might take a 2 also, Aaron, but this is packing very well with the soft, so it's great.
This little turn.
Yeah, this is a tremendous coil. I love the soft coil. I agree with Jay's assessment about the non-soft coils. They're great coils as well, but I don't think you necessarily need fibered in this location. I think it's really important to get a dense pack. I mean, there's really not another, I don't know of any other coil that packs this tightly, at least peripheral coil. This is really just a great result just for one coil. I don't think you need to put any more in, to be honest.
More than that,
I'm not going to put any more in.
No, I mean, when I started, I would put slightly shorter coils, and then I ended up putting more. And I think a lot of people had that experience. And then eventually we just kind of get comfortable with the length that we want. Kind of like Jay just comes out of a holster. He says 315 and it landed perfectly.
Yeah.
Yeah. You guys want to talk a little bit about how many vessels you think we need to embolize in these cases? I mean, this is a great example of where we see the blush, but there's obviously other rectals that are going to feed this. And so do we base this on what the angiogram looks like after we embolize each one, or are we going to just go and do all the different rectals that we see on the angio, regardless of whether we see blush? What do you think about that, Jesse?
Aaron, I want to interrupt you for 1 second. See that?
Yeah.
There was a little tail on that coil, and when I pulled the microcatheter back, it was already detached, but the tail came up a little bit.
Yeah.
I think these vessels sometimes are very sensitive with these coils. If that was a fibered coil, it would have come back a lot more. So that's why I would,
absolutely.
if you are going to use some of these coils, the soft, it's kind of like a protective mechanism to use the soft one, because I'm going to do a run right now and you'll see that kind of occludes.
I've also seen, especially with some of the stiffer coils, you can sometimes run into a little micro perforation, and that sometimes, creates a little bit of a headache, I think, in some of these cases, because you really don't want to have that if you can avoid it.
Yeah. So, going back to your question, I mean, going into cases, I always think about the 3 to 6 number for vessels to treat. I don't know, Jesse, what you're.
Yeah, I mean, I think we're usually in that range, but I do think you have to check kind of like above that little bifurcation of the superior rectal after you embolize a couple. Sometimes you'll see additional ones pop up, air supply in the CCR. So, just like checking after you do your main initial branches that you've selected for embolization is important too. So.
How does everybody decide when you're done? Are we looking for complete devascularization of the area, or are we going to leave some vessels open for to allow perfusion of that area? I mean, what's the end point here? How do we decide?
I would say we're really looking to take away any ones that are kind of vertical and perfusing that area, near the pubic symphysis where we're seeing CCR. If there's a significant blush associated with that, then, it's very vertical, then I want to take care of it. But otherwise, I'm not trying to devascularize the whole area, but really those vertical areas that lead to blush. So.
Right.
So on this,
so what do you think about that little vessel here?
I think you might want to get it if you can. So
yeah. So that vessel wasn't apparent on our first run. So this kind of shows that.
Itself. Yeah.
Yeah, that you have to kind of keep reevaluating things, and other branches will pop up. So if you just pull out right away, you might, kick yourself in the shin there.
Do you think this microcatheter will be able to navigate that tiny vessel, or do you think you need nitro or a smaller catheter? This is a tiny vessel. Looks like it's about 1 millimeter.
I mean, it may be occlusive here for sure. I think it'll go.
Yeah.
And then it's going to deform it with the wire and the microcatheter. So I think it's worth, doing a little puff, seeing where we are.
We have nitro ready.
I think to what everybody was saying, we have to, what was that? We have an idea of what we're seeing, where we're going to go in, but even after we embolize, it has to be on a minute by basis as things open up, as things appear more prominent, as things kind of actively collateralize while you're doing the case.
We have 2/8 here too, right?
It looks like you got into the origin pretty easily, and the catheter is tracking fine. That's a tiny
I
vessel,
needed a
really small.
I needed a wire. I'm not as good as Jay, but you know, I think it was not difficult to get into.
Yeah,
You
I
know,
would think you're good there. Yeah, just
yeah. The other thing we're looking for obviously is it whether you see some collaterals from the middle rectals here. Just you can kind of catch that on your angio sometimes. Jesse, are you doing general angios like aortograms at all to look at middle rectals when you start, or you just go straight for the superior rectal off the IMA?
I go straight to the IMA, and then I'm looking for big anastomotic connections.
FCC.
From the middle, and they'll almost always show themselves from that IMA run. And sometimes if you get more selective, you'll see it better. But yeah, I mean, pretty much just focusing on the IMA and the superior rectals. So.
How often are you doing secondary angios in the internal iliacs to look for the middle rectals? Does it happen?
Yeah, I would say, maybe 20% of the time, something like that. Yeah.
Speak of the devil.
You see that?
Yeah.
Now,
is there any value? Is there any value of cannulating it retrograde through the IMA circulation, or
doing some. Yeah, when we can, if it's got a proximal enough communication where you can retrograde get to it, then I've been doing it that way. So that's nice.
Yeah.
Yeah, I think that's what I like about the particles a little bit. It's like a little.
So these are the particles right now.
Yeah.
Saline.
You don't need a lot in this vessel for sure.
No. So we gave 1 cc of particles in the last vessel, and this one we're giving half just because it's smaller.
I'm practically just loading the microcatheter and then flushing it out, to be honest with you.
Right now he's flushing the saline.
Of course, when you're distal in some of these vessels, you can see anastomotic connections. You kind of make them show up. But the question is it something you have to go after?
Yeah. There's an operator pressure on the syringe situation. If you inject hard enough, you can usually open some things up. It's true with a lot of things.
Yeah.
The nice thing about the particle size that you guys chose is that it's probably less likely to cause any ischemic issue, even if it refluxes into some of these more proximal branches, which I'm sure particles at that size would, just given how small the vessel is.
Yeah.
Yeah, you can kind of see the blush from it, that middle rectal there, right? Yeah.
So here's a theoretical question that I would love someone to help me figure out, because I don't know the answer to this. Where do you think we want, from a micron size, where do you think, in an ideal scenario, where do you think we would want this embolic to end up? Do we want it to be, at the 100 micron level? I mean, assuming you didn't have to worry about ischemia. Do you think 300 is too small, or do you think that's something that would be reasonable
load it up and all that?
If it wasn't a particle, as an example, if it was some other type of embolic? What do you guys think?
Yeah, I don't know. When you're getting that small, I mean, you could probably get away with it, but I'm not sure the additional benefit of fighting at that level. But
the reason I ask is because we're, with this procedure, we've essentially taken a concept, hemorrhoid artery embolization, which we know works, but we've taken equipment that's pre-existing, particles and coils, and sort of modified the way we use them for this procedure. But if we were going to start from scratch and we were going to say, okay, we need a different embolic for this, and what I'm getting at is maybe a liquid would be better.
You're headed to liquid. I know this. We have this conversation, I think, about just about every procedure that we can. I think it's a matter of efficiency. I think it's a matter of getting the best embolization that we can. And I feel like with so many procedures, we've started in that place. And we've just kind of advanced to liquid. And I think hemorrhoid at some point in the future will be in that space. Whether that liquid exists now, I'm not sure. But I definitely think we're headed that way.
I think,
I agree with you.
And it a reliable, level that it penetrates to, I think that would be fine, like at the 300 micron level or something like that, which, I know those kind of things are in development, but yeah, I mean, as of right now, the information we have on liquids is, it's going to penetrate a little bit too distally. Dr. Vidal did some animal studies with Onyx where he got, full thickness necrosis of the rectum using liquid. Yeah. So, I mean, I would not be, maybe one day, but yeah.
This is a
the other issue
way.
with liquids, Jesse, is that we have to do so many different vessels, and we've not had,
Exactly.
we've been using the same microcatheter, and so if we were going to use a liquid for a procedure like this, I think we would need something aqueous, not DMSO or adhesive like glue, where we could reuse the microcatheter readily
there. I think
not worry about it.
Fine.
That would be key here.
Let it go and then let it flop down for the bigger one.
There we go.
Just like beautiful.
Beautiful.
Dan, you want to talk a little bit about what our X-ray equipment in this room, because I'm looking at the images right now and the coils look amazing. The runs look great.
Yeah.
This is our new Siemens Icono room over on the west side, and we both have a lot of great case that we've done in there. What's your experience been doing hemorrhoids and knees over there?
Yeah, it's the Siemens Icono platform. It's the newest Siemens machine that we have. Like you said, we've been incredibly happy with the machine. We do a pretty high volume of knees here, but to be honest with you, it's the prostates that are difficult. Getting good image quality over a knee isn't really that impressive. When you're doing a prostate at 35 degrees over an American-sized male, that's really when your imaging is going to be impressive, and it does it with low doses, and it gets it with good image quality. The image quality here is beautiful. There's no question about it. We really have no issues in terms of seeing what we need to do, and I'm rarely just increasing the dose the way I would with other commercial vendors. I just don't have to do it. You can talk about your prostate experience, because like I said, that's one of the hardest in terms of on a machine. I think a prostate is really an important test for a machine.
Just that was a 2-8 coil, by the way.
That was a 2-8 coil. Okay.
That was a 2-8.
Yeah, and that vessel is not going to accept any coil perfectly. It's so small.
Yeah.
But that's actually a great result for that size coil, I think.
Laying them out in this location, I think, is a totally fine way to go.
They look great.
Nice. That's fantastic.
So now we kind of see where we have to go on the other side too, right?
Yep.
So let us do that.
I like to do the run at the bifurcation of the rectal, sort of at the top. So you obviously did a great job on that side. But what I typically do is I go up to the bifurcation and just do a more aggressive run, so I can see. You can already see that there's a rectal going down there. That you're going to probably want to embolize, but there may be a third.
I'm pulling back a little bit, and I'll do another run up higher, like you're saying.
I'm doing some power runs from right before that bifurcation through the micro too, which have been nice. So
yeah. My original run was a power run, which I still want to show at some point, but
through the micro.
No, we did to the base catheter. You can just do the top of the base catheter. I don't know if it's appearing on your screen. So we're pretty well in there. Okay. We're seated very, very well from radial access here.
Gonna get in that.
And
the nice thing about radial access, Dan, as you guys know, is that you can put that base catheter pretty far into the IMA if you need to, particularly if it's like a vertebral shape or burn shape that allows you to sort of drive it over the microcatheter to get a little extra purchase if you need it. You don't have to. But
ours is pretty
far
on the small side.
Ours is pretty far and out of necessity, because the 125 catheter with the 150 prograde, you kind of have to make sure that you're
you're not at the mercy of a reverse curve catheter that may have to, depending on what you're using, just hang out at the ostium of the vessel. Here we're essentially right above this SRA bifurcation with our base catheter, so we have really good stability here.
Yeah, that's why I mentioned before I like the 110. I think Jesse mentioned that too, right? Because if you have the 110, you don't have to worry so much about pushing it distally if you have that option. But in the young patient, it's not an issue at all. Sometimes it's important in an older patient with a little more tortuosity, and it becomes challenging. Hey Jesse, what are your thoughts on the different grades of hemorrhoids and the classification system and how well they respond to embolization in general? Have you seen a difference?
I think the really most important thing is their bleeding. The bleeding is their main complaint, because you can have some pretty significant bleeding even with grade 1. So I think surgeons, we spoke with a surgeon at Gust recently about this, and they don't really think about the grades so much as far as it's nice to know, but I will say the data isn't really as robust for grade 4. They just have more severe disease, fixed prolapse, so for those patients, it's a little bit less clear, whether they're going to get as much benefit just because they do have much more severe disease and fixed prolapse that is not going to really be addressed with this procedure. But, I think there's a role for it there too, depending on the patient. So.
Yeah. Can you talk a little bit more about kind of your evaluation in the office? What are the hard stops? Who do you think is going to be a great candidate? And you tell them, oh, this is perfect for you, or, I'm not sure this is really going to be right for you.
So, we're really looking for people with bleeding predominant symptoms. Right. Often they've maybe, they may have failed some conservative interventions or in-office procedures. They may not be interested in them, or they may be needing to kind of potentially consider a surgery, but not, be interested in that, or, not be great candidates for that. So we kind of talk through that. Usually it's around, we use the French bleeding score. Usually it's around like a score of like 4 or above, where we're really talking about significant bleeding symptoms.
Mm-hmm.
Scoring system isn't perfect. There's some variability there, but, we're not looking for, a little bit on wiping, once a month. We want something a little bit more substantial that's affecting their life, before we're even talking about this. I want, them to have at least some point in the last, year, preferably, to have had at least an anoscopy to, visualize the hemorrhoids, see that is in fact the cause of the bleeding. If they're having pain as a primary symptom, I really do want to make sure that they've been evaluated for things like an anal fissure, because traditionally bleeding internal hemorrhoids are not supposed to cause that much pain. So if that is a main focus symptom for them, then, we want to make sure that a fissure isn't the actual cause here. As far as colonoscopy, I want them to be up to date on a full colonoscopy. It doesn't have to be as recent. If they have known hemorrhoids, we've seen them semi-recently, but an anoscopy in the office is easy to get done, a lot easier than a full colonoscopy. So just having a colleague take a look. And there's some IRs that are starting to do anoscopy as well. I haven't really broached into that yet myself, mainly because, we have collaborating colleagues, and I think, we should take advantage of their expertise, on that. But that's certainly something that is apparently easy to learn from what I've heard. So.
Yeah, I think a lot of the people that are coming to an interventional radiologist, they've done other procedures, they've failed those other procedures. I think that's universally true in IR for a lot of things. So for you, if they've had banding, clipping, whatever it happens to be, does that impact you at all? Do you say you'll do slightly worse, slightly better? It makes no difference to you. I can tell you in my practice, it doesn't dramatically change anything.
No, it's not changing anything dramatically for me. If they've just had another procedure, I might say, we should give it a few weeks and see if that one works, but otherwise usually by the time we get them in, we kind of know.
Doesn't even have to go down even if you're just.
I did a guy the other day that was getting sclerotherapy every 3 weeks for like years, just for like trying to maintain the situation and not have it be, untenable. So,
inferior than inferior.
I don't think that really bodes
either. We could probably.
This is looking nice.
So it looks like you guys are trying to navigate just a little bit further past that small, tiny branch there.
We're at a little trifurcation here. We're going to get into at least the bifurcation.
You can. It might be a great spot just distal, so you could treat both at the same time, is what I was thinking.
Yeah, that's probably the plan. Is just to get, if the coils behave well, especially with the soft one, you can get them to kind of pooch into both origins.
Yeah.
More stylistic than necessary.
I think it's really important for the audience to sort of understand how small and how difficult some of these vessels are to navigate, and you guys are really expertly navigating them with a 2-4 microcatheter, which is I think very impressive.
All Dan right now.
Well, I have to use a wire. Jay just sends the microcatheters expertly, and it magically knows. Unshaped microcatheters go wherever Jay wants them to do on hand.
The only thing
really Dr. Vidal doesn't use a wire either. He just sends it down. He's magical too, I guess. I'm a peasant who needs a wire, sometimes. Yeah.
So that's another area I think that we're seeing a lot of improvement, because I think more and more we're getting into procedures, knee being one of them, where we can use angled microcatheters, and this is definitely a space where there's a future where we may not need it at all. As again, Jay has expertly demonstrated, an angled microcatheter, there's a world where the right one can just take care of this whole procedure for you. That's great.
Yeah,
it's a great angio too, because we're seeing that middle rectal blush come in at the end.
Yeah,
Just
perfect.
It's apply right there.
Mm-hmm.
So again, we'll go back to our particles. This one should probably do a CC just because we are seeing some compensatory flow from the middle.
And you guys diluted those particles, the 20 cc's or different. Wow, there's a middle rectal there too. 20. Yeah.
Yep, 20, and then we'll do a CC.
Okay.
I mean, I think it could handle it. I'm usually just starting with a smaller amount, especially given the small vessel. But I mean, I don't think it's.
Do you do aliquots?
I do. Yeah.
What do you typically do?
I start with
0.3. Obviously, it's dependent on the vessel, but
yeah, usually start with 0.3 or so because these are so tiny.
And Jesse, you're using 500s, or I missed what you said before.
I'm doing 5 to 7. Yeah.
Okay. Got it. What do we tell patients about recurrence? So like you have a great embolization result, 4 to 5 vessels are embolized. What do we tell patients about, number one, success rates, but also about recurrence rates at, let's say, a year, 2 years?
Yeah. I mean, we don't have good data out, for several years, obviously, but yeah, I'm telling them, basically all treatments for hemorrhoids have a recurrence risk, even hemorrhoidectomy. They don't treat every single column, because then they're at risk for stenosis and things like that. So everything has a risk for recurrence. That's not the bar, but as far as needing another embolization procedure to get good control of their bleeding, I give them around, a 10 to 20% chance of needing a second procedure. And I usually give it about 3 months before we make the decision to do that. Dr. Vidal, he actually makes an agreement with his patients that your bleeding will not be completely gone. We're trying to get it to a manageable level where it's not affecting your life so much. So that's not really, no bleeding ever is not really the expectation.
Yeah, we're right at that bifurcation.
And you said you wait 3 months before you repeat the angio and do maybe a secondary embolization. Okay.
Yeah, there's some patients where, of course, patients respond within a month and a lot do, but there's some patients that it just takes a little bit longer to completely respond. So I think the 3 month mark is where we're usually pulling the trigger on a second procedure if needed.
You see that no wire technique?
Yeah, we like that. That's impressive.
I mean, I learned it from Jay just 3 minutes ago.
Yeah. I do the 3 months as well, Jesse, where we talk to where no decisions are made about any other treatments for 3 months. Let's see where the dust settles here.
Yeah, absolutely.
What are you telling patients that are coming to you in pain and there's no bleeding? I get a lot of those.
This is not your procedure, unfortunately. So I'm referring them for for banding or depending on their situation or to surgeons. Yeah, I mean, I have done a couple for that early on. Their vessels are super tiny, super friable, and they might get some reduction in size or pain, but it's not as reliable. I think because they're not going to have. I mean, to me, if they had hypertrophied vessels that we could really treat, they probably would be having a little bleeding. So.
Yeah, I've had patients that have alternative symptoms, and I said, basically, I've had some patients that have had improvements, but that's not going to be the primary. If that happens, great. It'll be a little bonus, but you're here.
I told them it's a bonus.
Exactly.
Studies have shown some improvements in pain, but they all had really bleeding symptoms as well. So yeah.
What size coil do you have here? I would assume it's a 2, but you tell us.
Yes, but back to the 2/8 soft.
Great.
Let's see. Okay. And it's forming nicely here.
Yes. Looking good.
We might place another one because we're kind of selective here.
Yeah.
So we'll come back.
You want to do the same thing again? Same 2/8 or 2/6 or longer?
Probably do another 2/8.
Another 2/8?
Yeah. But I'm going to do
Jesse, when you bring somebody back, let's say at the 3 month mark for a second embolization, are you automatically going into the internals to look at the middle rectals in that scenario, or are you still going to go and look at the IMA primarily?
Yeah, for any take back, we're going and looking at the internals and seeing if there's a significant middle.
Are you starting off radial for those, or are you going to go grind too? For the middles?
I mean, yeah. So I mean, for that, I guess we've got to think about, are you going to have to be switching out catheter things? I mean, I think you can certainly go radial with a longer radial catheter, and that might solve all those issues. So I think that would be fine.
That one still.
I've done femoral for them too, and then catheter changes aren't such an issue either. So
my general feeling on this, at least based on this angio, it looks like you said you guys were going to do that's all just one coil. Looks like, right? Yeah.
That was one coil. I'm going to place another one here because there's a branch coming off. Place another 2.8 here and see if it passes.
Yeah, I mean, the interesting thing is it coming there, or is it kind of that more superior medial branch that's coming off? Is that what's feeding it?
Yeah.
You'll see. I'll do a better run right here. Do we have saline? Actually?
You could also
show
you could also take a 2.8 and cross the other branch if you wanted to. I would imagine.
Yeah,
that probably would be fine too.
Kind of bifurcated like we did on the patient's right.
Yeah, it might just cross it right up across.
See, there's another branch there, kind of.
Yeah. So now that one's where it's showing itself. Yeah. Mm-hmm.
You can see the middle rectal at the end there.
Mm-hmm.
Is your suspicion that this is going to be the end, or do you think there'll be more vessels?
My suspicion is that there'll probably be one more that popped up.
Yeah,
but
that's
we'll take a look.
coming from the other branch.
Mm-hmm.
That's great.
The more you look, the more you find with these sometimes.
Yeah.
But being able to see that amount of blush, even after embolizing, 3 separate vessels, is just sort of, reemphasizes the point that this territory is just so vascularized.
It is
probably more so than any other vascular bed that we work in, maybe minus the stomach, which makes it challenging, right? I mean, this is why this procedure is hard. The microcatheter work is not always the challenge. It's finding all these vessels that could be the hard part.
It's challenging, but it also makes it possible, makes it safe. So it's
it's the good and the bad of the collaterals, right? It's maintains some degree of perfusion, but the recurrence.
But yeah, I mean, the limits are probably farther than we've even been pushing them really on like how much you can get away with. But of course, we don't know exactly where those limits are. Yeah.
It's going to pull back a little bit for my post run here.
Interesting thing is the coil. Yeah, that one didn't really shift.
So Jesse, a lot of patients watch these videos because they find them, even though these are more technically oriented, there's also a lot of patients that like to see this just to sort of understand what the procedure's like, but also, what happens after the procedure. Do I
wait a second and see how it flows?
What does my arm look like, or what does my groin look like, and what's the post-procedure care look like? So can you tell us a little bit about your post-procedure protocol and what you send patients home on and all of that?
Wait for this point.
So one of the great things about this procedure is that, you really don't have to change much about, what you're doing already. So all of these patients should already be, doing, fiber supplements, things to prevent constipation, whether that's a softener or laxative. So really, I just make sure that they're preventing constipation. Usually they're already doing those things. And then otherwise, I don't send them home with any pain medication because usually they're not having, pain afterwards. And if they are, I want to hear about it. So, yeah, really, really very straightforward. So just their standard precautions related to the peripheral access. So, yeah.
Yeah. So just to point out,
what do you think? Are you sending patients home on anything besides what Jesse mentioned?
When I first started, I was doing some pain meds, just out of precaution, Colace, a little breakthrough pain meds. A couple of people experienced some pain. I don't want them to be suffering. Like one patient said he had like pretty significant discomfort for a few days, and that was with 5 to 7. So I don't know if that was chalked up to that. So increasing the size of the particle because of that. Yeah, just good diet, some rest. No Valsalving, no power lifting, heavy lifting, things like that could maybe exacerbate some of these. Probably a little bit longer. I tell them for 3 days instead of the typical 24 hours. That one patient that did have pain, we did it on a Friday. He's still having pain on a Tuesday. We, brought him in. We gave him a Medrol dose pack for any inflammation, and he felt better with that. I don't know if it was, placebo or not. We also send them to our colorectal surgery colleagues, but it's a precaution because he was also insistent on seeing someone too, a little bit, like just to make sure everything was okay.
Yeah.
And no big issues, but since then,
pressure, like tenesmus, those
yeah.
afterwards, I think are a little more common. So yeah.
We actually see that quite a bit in patients when we coil the rectal artery during prostate embolization. They get that.
Okay.
Maybe not to the same degree that we would see here, but absolutely. Sure. It's something that you just really have to treat that symptomatically, I think. That's a great result, guys.
Beautiful.
Yeah. One nice thing that we, on our initial puff after we placed that second coil on the left side, you can see the very superior end of that second coil is kind of going into that other branch that was feeding. Mm-hmm. Initially, we saw flow there, and I was mentioning whether or not we should drop another coil. We decided, and by we, I mean Jay, decided to give it 60 seconds and then immediately, took care of it, and nothing else was necessary.
Sometimes you need a little time.
Really nice.
We have a 5-French catheter pretty far down. So I'm going to remove my microcatheter here and do a hand injection through that just to
see what it's looking like now. See if anything posteriorly has popped up or anything like that.
Right. I like having the 5-French down here for this reason.
So I am doing CTAs on these people before, in part because we're trying to see what the utility is of that. I will say, like, most of the time, though, if you're seeing a middle rectal that looks significant on the CTA, you're also seeing it from this IMA run. So I don't think we're missing like a ton. I think we've had one where we could see a big middle rectal with an associated blush that we just could not see on the IMA run. But that was one case so far. So I think most of the time you can see it.
So I'm injecting pretty hard here. And, on the original run, we had a very nice flush of the corpus cavernosum recti. I'm not appreciating that much. There is that left-sided branch. It's coursing medial that's going down, but it doesn't look that hypertrophied.
No.
It's that distal. And I'm going to leave that alone.
This is a great result. I mean, you still see great rectal perfusion. Yeah. You just don't see that cavernosal perfusion down at the bottom.
Were you guys able to find the original run from there? Or?
Yeah. How do we?
I think when we de-identified, are you able to pull up the original run on the other without?
Just want to show that pretty area of blush where it was dropping down.
Okay. Yeah, we can show that. Give us a couple seconds and we'll pull that up. We can actually put this maybe as a reference for comparison. Are you able to see that on the screen, the reference?
But Jesse, what do you think of this for an endpoint?
I like it. I mean, you could, if you wanted to, like, interrogate that one that you're seeing coming off the left side. But, I think that's why I want to see the initial run, but I think you've addressed all major areas of blush here. So,
what's everybody's follow-up protocol? When are you going to see this patient, Jay, to see how they're doing?
We do a phone call next week just to make sure that everything's okay. So I'll call her Monday, Tuesday, just to see how our weekend went. And then I'll see her in 2 weeks, in person to see how things are. And then, 2 weeks to a month, depending on how my phone call on Monday or Tuesday goes. Okay. And then 1 month, 3 months. And then like as needed after that, if things are improving, up to 6 months, actually. I see these up to 6 months. Yeah, and they can call and get in touch with any questions in the meantime. And so if they do have, like, let's say they're bleeding, every week or something like that, and it starts going down a little bit, and they're concerned that it's not gone. Like Jesse was saying before, we'll wait till at least the 3-month mark to make the decision about a second intervention, unless obviously they're having, like, either worsening or change in their symptoms where we have to escalate and evaluate things earlier with, like, a CTA.
This is a great result, Jay. Awesome job. Any last minute comments, Dan or Jay or Jesse, before we're getting close to the hour mark here?
Yeah, really, we were going to try to show you that initial run. Can you hang out with us for just a second?
This one.
Yeah, I mean, we talked a little bit about it with the embolic, our impulse to transition to liquid. I mean, what do you guys think is going to be dramatically different? I mean, Jesse, 3 years, Aaron, 3 years from now, what are we doing that's going to be different? Or maybe nothing at all. Maybe we're doing it the same exact way other than embolic. Do you think something's going to change in terms of imaging, follow-up, our knowledge of who's going to do better or not?
Dan, if I was going to design an embolic material for this specific procedure, because obviously we haven't done that yet, but if you were going to, I think we would have to understand exactly how distal we want that to go.
Yeah, let it play.
Yeah. So we're debating whether we use 500 or 700 or 900 or whatever size particle. We have to have a liquid that has the ability to get exactly where we want it to go, not too far, and also not too proximal. And at the same time, we know that coils are not going to occlude vessels as readily as a liquid. We've seen that in other vascular
100%.
territories. So I think that's a wow, that's an incredible blush there, by the way.
Beautiful classic look here. Great.
Yeah, I don't know that I see that very often, but I guess this is a younger patient, so the circulation is excellent. But going back to what I was saying about the liquid, I think we would have to sort of think about where we wanted it to end up and design it that way. And there's obviously lots of aqueous-based materials that exist or are being studied now, but we have to, think about, maybe customizing them specifically for this procedure.
Yeah, I agree. I mean, we don't want permanent distal occlusion like that. That will not allow we need these collaterals to keep this area alive. We not want it down to the capillary level, with a liquid. So I would say, we need to define better, what micron level we need this to stop and see if that can be reliably obtained with a liquid.
Yeah.
All right. So now that you've seen the pre with that nice blush, we're not pushing it anymore.
I think you nailed it.
Yeah.
This is an incredible technical result, I think. Really impressive work, guys.
Really nice.
There's just that one little one that's going down there, but it doesn't seem hypertrophy to me on that. And I do like leaving some normal looking vessels behind if I can.
Absolutely. We're not trying to take everything out. So I think this is
not trying to take everything out. And I think, we don't have that blush anymore. So I think hopefully her bleeding will resolve
100%.
pretty soon.
I think she's going to do great.
Well, all right, guys, we're just going to close up here, I think. Thanks, Jesse.
Awesome work.
I really appreciate it.
Thanks, everybody.
Jesse, thanks so much for joining us on the West Coast time, and looking forward to seeing everybody soon.
All right. Take care, guys.